So first of all, I want to thank Henry. He and Moira found me last year when I was doing simulation after we opened our newly designed simulation center that I had the fortunate opportunity to help design. And I want to thank Brian and Al for sort of welcoming me into the MIDAS family. So when I first started doing simulation-based research, and it's a little different type of simulation, and we'll talk more about that, I've always thought, we needed to do more than just these single studies. We do a lot of these sort of one study here, one study there. And so I was always talking about we have to do more, we have to do more, we have to, just do bigger studies. Never did I think I would be standing here talking about big data, big science, and all of that. This is not really where I visioned myself a year ago. So it's really great to be a part of this. So what I'm going to do is sort of set the background for you and talk a little bit about why this is really important for us to look at this in a different way. And so I'm going to talk a little bit about nursing, because nursing is important to all of you, whether you know it or not. You will soon, if you've not been in the hospital yourself, at some point in time, you will be, trust me. And nurses are your best ally. Physicians are great, we love them, but nurses are your best ally because they are the people there 24/7 for you. So in 2014, there were 2.7 million registered nurses employed, and they predict that this is going to increase by 16% between now and 2024. This is great, we love it, job growth, it's great for us. We don't have to worry about finding a job, we're excited about that. But some of the concerns that we have in nursing is turnover. And turnover is tricky to measure for us in nursing because some turnover is okay, and that just means that nurses are moving within their institutions from maybe one unit to another, or it's job promotion, it's good turnover. Sometimes it's not so good because they're moving to other institutions, or maybe they're leaving a nursing home and going to work in an acute care hospital. But no matter what they're doing, turnover is costly because nurses need a lot of orientation no matter where they go, even if they leave one unit to go to another unit because of the complexities of patient care. One of the things that we do know about nursing turnover is nurses leave their first jobs at a rate of about 17.5%. And this was just recently measured. These results were published in 2014. And by the second year, they're leaving at a rate of 33.5%. That's huge. That tells us that something's going on within that first 1 to 2 years. Why are they leaving? And there's a lot of reasons why that's happening, and one of the things that we know is there's some amount of stress, burnout, frustration with that first job. And so why is that happening? What can we do to better prepare those nurses? So we'll come back to that. The other thing that we know that's going on in the workforce is the demand for nursing is rising again. We knew there was going to be a nursing shortage. We got a little bit of a reprieve in 2009 when we were expecting a lot of nurses to retire, and they didn't because of the economy. But now we are losing nurses faster than we are able to bring them into the workforce. Part of the reason for that is a faculty shortage. We don't have enough nursing faculty to bring students into nursing schools. The other thing that we struggle with is placements for students in clinical. And med schools struggle with the same thing, and so do a lot of the other health professions. We need training slots for them, and there just aren't enough training slots to go along. So where do our nurses practice? Well, who do they care for? They care for people who are very ill. Now, sometimes they go to acute care floors, your sort of general care units, but even patients in the general care units. When I started off working in neurosurgery back in the early 1990s. Patients would come in for back surgery, just a simple laminectomy, remove a disc, remove some of the stuff. Patients would stay for a week. Now, my husband just had that same procedure. He didn't even get admitted. It's amazing. So the people who are getting admitted are sicker, they stay less time. Our new graduate nurses who graduate after their 4 years often get employed in intensive care units. They work in pediatric intensive care units, they work in open heart intensive care units, they work in the emergency department. Our hospital here will hire new grads into their emergency department. They go through a 6-month internship. But we need to prepare them in our schools to be in the best position we can so that when they get out there, we at least make sure that they are successful. Because if the hospital's going to invest 6 months into them, you want them to succeed. That's a lot of money to invest in our new graduates. So, how do we best educate and evaluate our nursing students? Because one of the things that we want them to be able to do is apply what they learn in school to novel situations. Now, for those of you who remember, when the plane landed in the river, so I read Sully's book. So most pilots train where? In simulators, right? They learn a lot of what they do. In fact, most of what they do, they learn in a simulator. Do you think there's a simulator for for landing planes in the water like this? No. They have no data. So they can only simulate what they have, as you all know, right? Big data, right? You all know the data better than I do. You see, I have no fancy formulas yet. You're not going to find any. Because, I don't know how to do this stuff. There was no data to create a simulation for water landings like this. So the type of simulations that they do to practice these are what they call tabletop simulations. So they can discuss it. They can imagine what they would do. So basically, you take what you do learn in a simulator and the things that you know how to do, and you sort of apply those to novel situations or new situations, and that's what he did in order to land. So that's what we have to do with our nursing students. We cannot forecast all the things that they will be involved in, so we have to teach them to think like a nurse, to apply decisions, clinical thinking, critical judgment, so that we teach them how to care for these types of situations, and then we hope they will apply those decision rules and those judgment skills into all of the novel things that they will experience, because people are people. They don't behave in the same way. Now, are we going to train them in situations like this? Not going to happen. Sure, they go to lecture, but even our lecture is turning into more flipped classroom, case-based learning. Most of our students, even if they sit in a classroom like this, they will spend little time listening to lecture and more time in case-based learning. So what we're now doing is employing a lot of simulation. We are replacing anywhere from 25 to 50% of our clinical time in simulation, because we can control what happens in simulation. We can give them dedicated experiences and know that they will get those experiences that they need in order to be more successful in their first jobs. So this is one of our simulation rooms. Now, this is Victoria. If anybody happened to see any of the news that's been running around or seen any of the little videos, you will know that Victoria can give birth every 10 minutes. She is a workhorse. She has her pregnant belly, and we can load her up with a new baby every 10 minutes. There's her baby there. He's out. So with this sophisticated $80,000 birthing machine, we can give students that experience. So our undergraduates can learn how to care for mom in labor, can learn how to care for the baby after born, learn newborn care, learn what to do if there's problems during labor. And our graduate nurse midwifery students can learn how to deliver that baby. through all kinds of birthing issues. So anything you can imagine that can go wrong during birth, we can simulate that. The only thing Victoria can't do is twins yet. And I'm sure at some point in time, well, we can actually, I think, put 2 babies in there, but you can't deliver them both. So, you know, that'll be the next time around. So this is what it looks like for the students. You can see there is the, it's kind of like a window there, like a one-way mirror. And the students are in there caring, and this is us behind the control panel, sort of operating the simulator through our computers. And then you can see there's actually 3 screens here. So we have 3 cameras in the room. We capture digital feeds. And then this is a vital sign monitor. We capture vital signs from Victoria. We actually can put her on a monitor, so we can capture all the uterine contractions. We can capture fetal heart tones. It's all simulated data. But you know, we can capture all of that while this is going on. Then we move into debriefing. And we do sort of an after-action review. This is where much of the learning occurs. As we go through that, we can pull up the video, we can go back and look at everything that's gone on. So a typical student for a rotation will go through anywhere from, like I said, 24 to about 40 hours of in-person simulation in the lab. And this just kind of gives you an idea of some of the things that they'll go through. We'll talk about communications, handoffs. This is for pediatrics. Immunizations, we might deal with some language barriers, dehydration, emergency department visits, pneumonia, respiratory arrest, traumatic brain injury, motor vehicle accidents, things like that. Palliative care, end of life, how do you deal with a child who's dying? Our students also do some virtual simulations, so they'll move into the virtual world. You saw a little bit of this yesterday. One of the speakers pulled up some of the early virtual stuff where a student will interact with an avatar. And this is one of the avatars that we use here. It's by Shadow Health, and the student will actually interact with the avatar, do an assessment, ask them health history questions, and communicate with them. And then this is another one where they'll actually enter almost like a game-like environment and do some assessment, look at their health history, look at their medical record, and then they actually have to make some decisions about how they're going to treat their patient. What's nice about that is then we'll actually get some results from those computer interactions. What this tells us is how many mistakes that they made when they went through the simulation, and it actually ranks them. Was it a minor mistake, was it a moderate, or was there significant risk for harm to the patient by things they either forgot to do or did that was a wrong thing? And so they can go through and do these multiple times until they get it right, until they achieve a good score. The other thing we can do, I talked about that sort of clinical judgment. They need to really learn how to think like a nurse. Now, these are rubrics we actually have to score by hand, watching the videos, which is very time intensive, which is one of the things that I'll talk later about that we're working on. And we can go through and measure student improvement over time. How well are they getting the ability to sort of look at this, gather the right data, make decisions with that data. Now, in all fairness, we ask our students to give us feedback as facilitators and debriefers. How well are we doing in helping facilitate their learning process? We're also interested in what we call high-stakes testing. So again, we want to make sure if our students are going into the hospital, even as students, that they're able to care for their patients without creating a situation where they're introducing infection into the environment. Are they washing their hands? Are they doing sterile procedures correctly? So every clinical rotation at the beginning, we put them through what we call skill competency checkoffs. And there's a graded rubric where they get a 1 for doing it correctly, a 0 if they miss it, and we make sure that they're doing hand washing, medication safety checks, procedures in the correct way. Are they, doing all their checks? Are they introducing themselves to the patient? And it's, it's these skill rubrics. And we have about 10 to 15 of these that we use. All of this data we have been collecting for years. Of course, it's all in paper form. So one of the things that we're going to be working on is, digitizing that data so that we can kind of look back and see how are our students doing across time. How can we use that to individualize things? Another thing that we have is we have Kaplan testing data. So Kaplan does these standardized tests. Now, all of our students have to take an exam in order to get their registered nurse license. They take the NCLEX. It's a state exam. And these Kaplan tests that we do help them prepare for that examination. But they also give us a lot of really good data on our students. And what we're finding in just the little tiny peek that we've done in there is, well, one thing that we found is as we replace the clinicals with simulation, we took a quick peek last year, students are doing just as well on their Kaplan exams. We did a peek on their clinical judgment scores. They're doing just as well, so that's great. By replacing clinicals with simulation, we haven't done any harm to our students because we never want to set them back. And we also know that maybe there's some correlation between how they do in simulations with the Kaplan. So again, a really huge, rich source of data that we can start to dive into. One of the things that sort of helps focus us on how we want to start to look at our data is a large study that was done, and it was done in 3 phases, and they just published the data in 2015. And it was sponsored by the National Council of State Boards of Nursing, which is the group that sort of really looks at this whole licensing and this NCLEX exam. And what this study found, so they enrolled a bunch of schools of nursing across the country, 4-year, 2-year schools, and they did a really nice experimental design. And they said, okay, this group does very little simulation. You do pretty much all clinicals. This group does 25% replacement of clinicals, and this group does 50% replacement of clinicals. And then we're going to see how everybody does on the NCLEX exam. We're going to measure the students' critical thinking. We're going to follow those students into the first 6 months of their new job. Because if we replace all these, clinical, which has been like the standard way we've, educated our nurses and our physicians and everybody, we want to make sure that they're successful. And they found indeed that no difference in NCLEX pass rate between these 3 groups, no difference in critical thinking. They were all just as smart, and they all did just as well in their first 6 months of their jobs. They had the managers rate them. Yep, everybody was great. But a really interesting finding came out. And remember back when we talked about turnover, and I told you that those nurses in their first jobs, 1 year, 2 year, high amount of turnover, and some of it's due to job stress? So what they found is that the nurses who had 50% simulation had a lot less job stress. Now, they don't know why, because that wasn't part of the study. But in talking with some of the people in the study, and those people had a chance to just sort of query a few of the folks that were sort of out there working. Some of the thought was, and in talking with a few of the subjects, they said, you know what? We didn't get stressed on our first jobs because we were so used to going to simulation and you just kept throwing stuff at us and we were always in the hot seat. We never knew what was happening. You'd go in there and the mannequin would code and die and all these crazy stuff would happen. So when we were on our first jobs, it didn't matter because we were used to it. Something different happened every day. We could go work in the ER and some trauma could come in. Oh, well, it's just like a day in simulation. And they were also used to getting a lot of feedback in debriefing. So it didn't matter if their preceptor said, well, you did all these 10 things wrong today. And they're like, okay, thank you. I learned a lot and I'll come back tomorrow and learn some more. So there's this positive effect of simulation on job stress. Wouldn't it be neat if we could validate that and we could figure out maybe simulation will help them survive and we won't see so much turnover? So where do we go from here? Well, that's where my connection to MIDAS and Henry goes. We need to look at how can we automate this data collection? How can we understand more about types of simulation experiences and figure out this less job stress and work with our hospital partners? So to do this, we can't be doing little one-off studies. We need to start collecting some big data sets or pulling all this data together and doing stuff that I had no idea how to do. Well, I mean, I kind of had an idea, but stuff that I need support to do, and figure out how data science can help us in simulation, and we figure out how to make a better nurse so they can take care of all of you. All right.
Really, percentage of women in a medical school, in physical sciences, in law school, and the red line would be computer science, which is the field where I belong. And as you